the big screen?
Yes, sir. Yes.
Okay, wonderful. Thank you. Thank you to both Vivian and Rita, as well as the organizing committee, for the invitation to speak to you all today. I really consider it an honor to be here, so thank you very much. The title of this talk is going to be called The Why, How, and What of the 2022 Critical Care Nutrition Guidelines. Just in case we run out of time or you have a question later, I did state my email address on the bottom left here. Please feel free to email me any questions you may have regarding this talk or anything else. I have served as a consultant for Baxter. However, nothing in this talk is related to my role as a consultant. So here are the objectives of this talk. First, I'd like to describe the differences in methodology between the International Critical Care Nutrition Guidelines. And that'll really form the why and the how. We're going to spend a lot of time on 2, 3, and 4, which is to delineate 5 questions that were asked in the 2022 Critical Care Nutrition Guidelines. We'll discuss the rationale and specific recommendations that are outlined in the guideline. And then we'll identify some, not all, randomized controlled trials which informed the 2022 guideline. And then finally, we'll outline the evolving knowledge synthesis and dissemination process moving forward. And that'll sort of shape out, again, some of the why and how things are being done in the world of guidelines. All right, so let's get started and describe the differences in methodology between the guidelines. Before we do that, and this is really an oversimplification here, but this is a schema of the steps and processes for creating a guideline. Okay, note that the steps and processes are interrelated, but they're not necessarily sequential. And for the sake of, again, oversimplification, I want to put these 3 key areas in here. So for number 1 on the screen, this is the formation of a guideline panel and supporting groups. And these groups work collaboratively and are informed through key stakeholder involvements. These groups typically report to an oversight committee, or in our case, a board, overseeing the process. For number 2 and number 3 on the screen, we utilize something called the grading of recommendations, assessment, development, and evaluation. That's an acronym for GRADE, G-R-A-D-E, which provides a transparent and sensible framework for specifying healthcare questions, choosing outcomes of interest, rating their importance, evaluating the available evidence, and then really bringing together the evidence with considerations, and this is really important, the values and preferences of patients and society to arrive at specific recommendations. And so this really is formulated into 2 key areas. The yellow and the blue are how questions are generated and how the evidence is actually accumulated and synthesized. And then number 3, which is how do we go from synthesizing the evidence to actually providing recommendations. So we'll take a deeper dive into that in just a few minutes. But in the world of guidelines, here's what's been produced over the past 7 years. And the newest guideline, newest meaning prior to the ASPEN update, is the 2018 ESPEN guideline. And I want to make just a couple of points about the ESPEN guideline. It's got some very many novel features, and I want to point out 3 of them. For example, the ESPEN guideline was the first that provided really clear nutrition terminology. So it defined things like hypocaloric, trophic. The guideline identifies and distinguishes the various phases of critical illness. It was the first to do that. So it defined what is the early acute phase, the late acute phase, and then the late or chronic phase of critical illness. And then the ESPEN guidelines also indicated the degree to which they agreed or disagreed with pre-existing ASPEN and Canadian guidelines. And so where does the 2021 update stand? Well, here it is right here. And you can see some of the key differences between the Canadian, American, and European guidelines with this 2021 update. So for example, you can see that the previous guidelines use things like meta-analyses, randomized controlled trials, and observational data in the 2016 American and the 2018 ESPN guideline, whereas the 2021 limited its study designs to just randomized controlled trials. The second key difference that you can see here is that previous guidelines offered multiple recommendations on numerous topics. Here, the updated guideline had 5 topics and provided 6 recommendations here. Now, it's really important to take note of the language that was used. So there's a symbiotic representation that's offered by grade. So for example, high quality of evidence may link with, what you might see as level A evidence, and a strong recommendation may be linked with what is called a level 1, recommendation. And for strong recommendations, the grade working group has suggested adopting terminology such as you can see here, we recommend, or clinicians should. For weak recommendations, the grade working group has suggested less definitive wording, such as you can see here, we suggest, or we conditionally recommend, or we cannot recommend. And I'll discuss in a few slides where recommendations are not made and the rationale for that as well. So let's take a deeper dive into sections 2, 3, and 4, where we'll delineate the questions, the rationale, and then identify specific randomized control trials. So a guideline panel should really define the scope of the guideline and the planned recommendations. And each recommendation should answer a focused and specific healthcare question that ultimately leads to an action. So the PICO format presents a well-accepted methodology for framing healthcare questions. And the PICO format mandates carefully specifying 4 components. The first component is the P, which is the patient population. And so these, again, are the patients or population to whom the recommendations are meant to apply. The I is the intervention for therapeutic, diagnostic, or other interventions under investigation. C is the alternative intervention. So it could be a control group, it could be a placebo group, for example. And then O is the outcome of interest. So for example, 30-day mortality, duration of mechanical ventilation. And there's other derivatives of this approach that exist. So for example, adding a T for time or S for study design, you may also see in guidelines and in other documents that use this PICO format. And in using this PICO format, the panel developed the questions that address major contemporary practice themes and determined time frame for the literature search, the target population, and the specific outcomes to be addressed. And so here are the a priori questions that were asked. And we'll go through these questions in detail, but in general, you can see that they all follow a PICO format, and it starts with an adult critically ill patient. So it already tells you who the population is, which follows by the intervention, right? Does, number 1, provision of higher versus lower energy intake impact clinical outcomes? Does provision of higher versus lower protein impact clinical outcomes, et cetera, and so on? So now that the questions have been asked, the goal is to summarize evidence and judge the quality of evidence. And so for guideline panels, the quality of evidence really reflects the extent to which the confidence in the estimate of the effect of a study or outcome is adequate to support a particular recommendation. And so now we're going to take a little bit of a deeper dive into how the guideline panel summarized evidence and judged the quality, strength, or certainty of evidence, but then also went from evidence synthesis to actually developing recommendations and strength of recommendations. So let's take a deeper dive into number 2 and number 3 here. So when we talk about evidence synthesis and evidence recommendations, you'll notice that there is a difference between these two. These are distinct processes. Again, the guideline panel should base its recommendations on the best available body of evidence. And it can use existing systematic reviews, or it can conduct its own systematic review depending on specific circumstances, such as the availability of high quality reviews. But GRADE recommends that systematic reviews should form the basis for making healthcare recommendations. And so again, the strength of recommendation really reflects the extent to which the panel is confident that the desirable effect of an intervention outweighs the undesirable effect. And so let's briefly take a look at how the quality of evidence is determined. So this is right out of the GRADE table. And by the way, if anyone is interested in learning a little bit more about the GRADE process, this is available free and online. If you just type in GRADE Pro or GRADE Handbook and EBM, you'll find that you'll find in the first search box that this pops right up, and you can find all this information there as well. And I'm just showing you snippets of it here. So although the quality of evidence represents, a continuum, the GRADE approach results in an assessment of the quality of a body of evidence into, as you can see here, one of 4 grades, going from very low up to high level evidence. And so, for example, to be considered high level of evidence, the guideline developers must have a very high level of confidence that the true effect in whatever they assess is close to the estimate of the effect in whatever is assessed. And so here's a table that outlines the factors that determine the quality of evidence. Now, we won't go through these in tremendous detail, but note that the study design is critical to judgments about quality of evidence. So for example, on the left side of the screen, you can see a schema for what a randomized controlled trial would look like. And a randomized controlled trial without limitations would provide the highest quality of evidence. But that doesn't mean it's not subject to bias. So for example, if we look at some limitations in study design or execution, you might say to yourself, wait a minute, I'm reading a randomized controlled trial, but it doesn't tell me if the patients are going to be randomized using allocation concealment. Or you might notice that there's a lack of blinding, or you might notice that all patients who were randomized weren't accounted for, what we call intention to treat. All of these factors can reduce the quality of evidence. So in other words, you have a randomized controlled trial which serves as the highest form of evidence, but then if there's some issues with bias, as we just discussed, it can reduce that level of evidence. On the other hand, observational studies. So on the left-hand side, on the bottom, you can see a schema for an observational study. Now, observational studies start off as low quality evidence, but they can be upgraded. So for example, if there's a large magnitude of effect from the observational study, that study can get upgraded. But you note that it won't ever get upgraded to the quality of a randomized control trial. Notice what's not on here. Expert opinion is not considered a category of quality of evidence according to GRADE. And we'll touch a little bit more on that later. So how do we move from rating quality of evidence into actually making a recommendation? So GRADE specifies 2 categories of the strength of recommendations: strong and weak. A strong recommendation is one where the guideline panel is confident that the desirable effects of the intervention outweigh its undesirable effects. In other words, the benefits outweigh the harms, or that the undesirable effects of an intervention outweigh its desirable intervention. And that is for a strong recommendation against an intervention. A weak recommendation is one for which the desirable effect probably outweighs the undesirable effect. So weak recommendation for an intervention, or an undesirable effect probably outweighs the desirable effect, a weak recommendation against an intervention. But notice that appreciable uncertainty does exist. Now, you might see other names for weak recommendations, and these include conditional recommendations, discretionary recommendations, qualified recommendations. But notice that these are not strong recommendations. What about no recommendations? Now, I inserted this slide to be complete, But every once in a while, a guideline panel will say, we are not going to make a recommendations. And that could happen because the confidence in the effect estimate is so low that the panel feels a recommendation is too speculative, or irrespective of the confidence in the estimate, the trade-offs are so closely balanced and the values and preferences and resource implications are not known or too variable that the panel just has great difficulty deciding on the direction of recommendations. And then finally, there might be two management strategies that have very different but undesirable consequences. And the individual patient's reaction to those consequences are likely to be so different that it makes little sense to think about typical values and preferences. And in that case, you might need to have a discussion between patient and physician to ascertain the patient's preferences. Now, it's really important to understand, the implications of a strong recommendation and the implication of a weak recommendation from the key stakeholders' perspective. And so the key stakeholders here are patients, clinicians, and then, healthcare policies. So, for example, if a guideline panel has a strong recommendation, and if you're a patient, then most patients would want that recommended course of action, and only a small proportion would not. Now, if you're a clinician on the front lines, most individuals, you might say, should receive that recommended course of action. And that adherence to the recommendation could be used as a quality criterion or performance indicator. So, for example, imagine someone said that, giving a high dose of protein, we have a strong recommendation for doing that. And every time you don't do it, you might get dinged, for something like that. This is why the strength of recommendations are going to be really important. And then finally, for policy, the recommendations can be adopted in most situations, again, including for use as a performance indicator. So the wording of recommendations have significant impacts for key stakeholders. And so again, recall, here are our questions. So after the process of searching and culling literature, abstracting data, synthesizing the data, and then formulating a recommendations, what is it that we ultimately came up with? And so let's get right to it. Okay, and so let's get right to question one. So question one asked, in adult critically ill patients, does provision of higher versus lower energy impact clinical outcomes? Now, it's really important to note that to be included in the analysis for this question, the trials, the randomized controlled trials, needed to randomize energy exposure without causing a secondary competing intervention, such as a shift from EN to PN as well. And so the recommendation was that there was no significant difference in clinical outcome was found between patients with higher versus lower levels of energy intake. And they suggested feeding between 12 and 25 kilocalories per kg in the first 7 to 10 days of ICU stay. Now, some might consider that the acute phase of critical illness. Now, again, in reality, we just don't know when patients transition between the early acute phase or the late acute phase, or between the late and chronic phases of critical illness. But in general, the first week of critical illness is sort of accepted as the late phase of critical illness. Now, this decision was based on having no evidence of benefit for for energy, and a lack of certain regarding the harms of energy provision. And that was consistent with those recommended in past guideline recommendations. And you can see that, again, the forest plot, when you take into consideration some of the newer trials by Doig and by Petros, for example, there is no signal favoring lower or higher energy. Now, there's some other rationale, though, for maybe a less is more. So maybe we're shifting towards a less is more strategy in critical illness. And these other rationale form the basis for the harms with too much energy. And that includes feeding intolerance in the acute phase of critical illness. There's data that seems to suggest that in the early acute phase of critical illness, pushing too many calories may lead to more feeding intolerance. The second rationale is endogenous glucose production is increased in the early acute phase of critical illness. So when there's hyperinflammation and catabolism, amino acids are getting funneled for gluconeogenesis. there's a ton of just endogenous glucose production in critical illness. And so if we add more fuel to a fire by giving more calories, well, that increases the risk for things like hyperglycemia, for example. The third is refeeding syndrome and malnutrition. Remember that the previous 2016 guideline recommending getting to goal calories sooner than later in those who have high nutritional risk. Well, that has to be counterbalanced by this potential harm, because those individuals who have high nutritional risk, i.e. those who are, for example, malnourished, they also stand to be at higher risk for refeeding syndrome. Which was observed in a trial by Gordon Doig, and the reference is listed here as number 5. The sixth reason is mitochondrial failure. And so recall that the mitochondria serves effectively as the battery. And so if you're pushing too many calories early in critical illness, well, that battery has to suddenly work extra hard, and it's already under tremendous oxidative stress. And then again, the final reason here is autophagy, which kind of goes again with oxidative stress. So if you increase the amount of oxidative stress, or if you push too many calories early, then the autophagic components of cell cleanup are impaired, and that can lead to worsened oxidative stress by pushing, again, too many calories. So there are other rationale for a less is more strategy early in critical illness. So here's the second question. In adult critically ill patients, does provision of higher as compared with lower protein intake impact clinical outcomes? Now, to be included in this analysis for this question, the randomized controlled trials needed to satisfy 3 criteria. Number 1, they had to report protein intake in grams per kilogram per day, not only as percentage of goal. Number 2, they had to have a difference in protein intake of at least 0.2 grams per kilogram per day between groups. And here's probably the most important one, which is they had to have roughly equivalent energy intake between groups. And that's because if you don't have equivalent energy intake, it's hard to distinguish the impact of protein provision from, again, differences in energy or micronutrient, for example, provision. And so 4 trials met these criteria, and there were data from almost 700 patients. And the recommendation is that because of a paucity of trials with high quality evidence, we cannot make a new recommendation at this time beyond the 2016 suggestion. So this was low quality evidence. The strength of recommendation was weak, but the idea here is that the 2016 recommendation calling for a wide protein goal, 1.2 to 2 grams, still stands. Now, I want to draw your attention to some new emerging data since publication of the 2021 guideline that may have an impact on subsequent guidelines. The first, as you may know, is the EFFORT trial. Now, EFFORT initially aimed to enroll 4,000 nutritionally high-risk patients and randomize them to more than 2.2 or less than 1.2 grams per kilogram per day of protein, and both of these are considered the standards of care. And the primary outcome when the trial was first designed was 60-day mortality, but that primary outcome has since changed to time to discharge alive from the hospital. And we should have some results from the EFFORT trial, hopefully in the coming months, which should impact future critical care nutrition guidelines related to protein dose. Here's retrospective data from Van Zetten, which shows a time-dependent association between protein intake and mortality. And so if you look at the green line with squares, these are patients who received low protein. That was defined as less than 0.8 grams per kilogram per day during the first 1 to 3 days of ICU admission. And what they found was that delivering a less is more during those first 3 days was associated with the lowest 6 months mortality compared to patients with higher and lower protein delivery throughout. Now, this was a pilot feasibility study comparing standard versus higher protein dose after the acute phase of critical illness. So again, they were building on the previous data that I just showed you. And they defined after the acute phase of critical illness as 6 to 14 days of ICU stay. And the primary aims were to determine recruitment and retention rates and protocol adherence rates. And indeed, if you look at this, they achieved a nice separation of protein dose between groups. That's the difference between the red and the green circles. Unfortunately, despite screening over 700 patients, only 8% met eligibility criteria over 20 months and 3 centers. And so what this group of investigators did was they expanded their enrollment criteria, and now they have a trial underway with an anticipated enrollment of 2,500 patients evaluating higher versus lower protein after day 6. And they're looking at a primary outcome of 90-day all-cause mortality. So stay tuned for the results of this trial. Okay, so here's question 3. In adult critically ill patients who are candidates for EN, does similar energy intake by PN versus EN as the primary feeding modality in the first week of critical illness impact clinical outcomes? So here is the punchline for question number 3, which is that we recommend that either PN or EN is acceptable during the first week of critical illness. And there's 2 things to note from question 3 on EN and exclusive parenteral nutrition. Number 1 is that, again, there were no differences in clinical outcomes between EN and PN, and this formed the basis for why PN or EN is acceptable. And this was informed by these 2 large, pragmatic, randomized control trials. And it was these 2 large randomized control trials that formed the high quality of evidence and the strength of recommendation for this recommendation related to EN versus PN. Question number 4 asked, in adult critically ill patients receiving early EN, does provision of supplemental PN to meet energy targets versus no supplemental PN during the first week of critical illness impact clinical outcomes? Now, to be included in this analysis, studies had to report differences in response to supplemental PN versus no supplemental PN. So 6 trials with data from over 6,700 patients met criteria. Of these, 5 reported mortality, which is what I'm showing you here. And what I'm not showing is that any type of infection was not different with adding SPN. Now, note, the 2016 guideline recommended the use of supplemental PN after the first week of critical illness in patients who are unable to tolerate more than 60% of goal protein and energy requirements. The trials that were included here began supplemental PN by roughly day 3, and most continued the therapy during the first week of critical illness. But again, note, there was no difference in infectious complications or mortality when this data was combined. And so based on the findings of no clinically important benefits, we suggested not initiating supplemental PN prior to day 7 of ICU admission. And again, note that this was based on high quality of evidence and strong recommendations. In fact, questions 3 and 4 were the only 2 that had the high quality of evidence and strong recommendations. Okay, question 5 was split into 5A and 5B. So let's look at 5A, which asked, in adult critically ill patients receiving parenteral nutrition, does the provision of a mixed oil formula as compared with 100% soybean oil impact clinical outcomes? Now, to be included in this analysis, randomized trials needed to compare PN with mixed oil against soybean oil as a component of PN, and they had to report clinical outcomes. Now, 7 trials met this criteria, and there was data from over 620 patients. And the punchline is that we suggest either mixed oil or 100% soybean oil be provided to critically ill patients who are appropriate candidates for initiation of PN. Notice the quality of evidence was low and the strength of recommendation was weak. Now, from those 7 trials that met criteria and data from over 624 patients, There was no differences in the clinical outcomes. The interventions varied in each of the trials. The duration of the intervention varied. No trial was powered for mortality. Most trials did not report energy. And then there was variability in the mixed oil emulsions that precluded comparison in the forest plot. In fact, 2 trials not even use an intention to treat analysis or analyze differences between those who completed the trial or those who didn't complete the trial, again, forming the low quality of evidence for this recommendation. Question 5B asked, in adult critically ill patients receiving parenteral nutrition, does the provision of fish oil containing emulsions as compared to non-fish oil containing emulsions impact clinical outcomes? Now, to be included in this analysis, randomized controlled trials, they needed to do 2 things. Number 1, which is obvious, which is compare fish oil against non-fish oil as a component of PN. And number 2, they needed to report pertinent clinical outcomes. So here's the recommendation. The recommendation is that we suggest that either fish oil or non-fish oil containing emulsions be provided in critically ill patients who are appropriate candidates for initiation of PN. Now, 10 trials met these criteria, and there was data from over 900 patients. So in these studies, the lipid emulsions was included as part of the PN regimen at the time of initiation. Now note, the quality of evidence of these trials was generally low. Most trials focused primarily on biochemical or inflammatory outcomes, and none of the studies had the clinical outcomes considered in this guideline as their primary outcome, and included a small number of patients. And so again, these findings therefore did not impact the recommendation, and data for things like infections, ICU mortality, hospital length of stay, they were reported in a manner that precluded the estimation of generating a summary statistic, but also generation of a forest plot. And the strength of recommendation was therefore weak. So you might be saying, well, wait, that differs a little bit from the ESPN guideline. Recall that recommendation 33 from ESPN said that parenteral lipid emulsions enriched with fish oil can be provided in patients receiving parenteral nutrition. A couple of things to take note. Number 1, that the grade of recommendation was 0, and it was a strong consensus recommendation. In other words, it was an expert opinion. And so here is the basis for the difference in theirs and our recommendations. And I'll give you 4 key things. The first is that ESPN did not perform a new meta-analysis. And so when they in fact refer to a previously published meta-analysis. The reason it's important to note is that when the estimated effect observed in one meta-analysis is not reproduced in another meta-analysis, it could be due to differences in inclusion criteria, which then leads to differences in the patient population, which then leads to differences in methodology between studies and differences in the overall quality of studies that are included. The second reason is that many studies cited by ESPN did not meet our inclusion criteria. In fact, we excluded numerous studies being for various reasons. So for example, one study was excluded because data was only presented in an abstract form. There were 4 studies that were excluded because they examined fish oil as an independent drug rather than as a component of parenteral nutrition. 3 studies were excluded because interventions were inconsistent with our research question. And then another 3 studies were excluded because the randomization was unclear. And some studies even neglected to analyze up to 1/3 of the randomized subjects. Number 3, our data represents the state of evidence from January 2001 through July of 2020. So studies prior to 2001 were excluded because there was concerns that critical care practices before that were not as good as they were now. So for example, we have improvements in things like glucose control, catheter care, and that would limit the generalizability of the results for patients that we care for today. And then number four, our approach maximized the quality of data. So rather than packing the forest plots with dissimilar studies of questionable generalizability, we chose a parsimonious approach that maximized the quality of the data while remaining true to the assumptions of study design and statistics. So let's take a big deep breath here. And so now I want to put myself in your shoes for just a minute. After hearing these 6 recommendations, you might be asking yourself some questions. And so here's some questions you might be asking yourself. First, was the guideline development process publicly available? Number 2, why were there so few studies in the forest plots? And then number 3, why did the guidelines not include expert opinion? I mean, ESPN included expert opinion, and the 2016 guidelines certainly included expert opinion. Why didn't this update do that? So let's take a deeper dive in and talk about the evolving knowledge synthesis and dissemination process as we move forward. And so recall, this is our process of guideline development. And so let's ask ourselves, as we move forward in the guideline development process, where can we make improvements? And so let's start with, for example, number 1, and think about some new methodologies and the rationale for those methodologies. So as we move forward, by the way, I want to give a lot of credit to Liam McKeever, who's done a lot of work in this space, and he is the director of guidelines for Aspen, and he wrote a wonderful paper that really outlines the new methodology in future guidelines. And if any of you haven't read it, I suggest you do, but this data comes directly from his paper. The first thing is that Aspen will be publishing an a priori protocol on their website, and they'll be inviting commentary for up to 1 month after publication. And the rationale for that is fairly straightforward, because a priori publication of a protocol will increase the transparency, and any deviations from the original protocol will be publicly acknowledged and justified. But it will also solicit feedback from key stakeholders. The second new thing that'll happen is there will be a clinical and bias panel. And so to facilitate better bias assessment, separate bias and clinical panels will be formed, and they'll be trained, for example, the separate bias panel to take over the bias analyses. And they will meet with the clinical panel to determine what sort of co-interventions or confounders need to be considered. They will then perform bias analyses using the latest tools, which includes Cochrane's risk of bias tool, also known as the ROB2 tool for randomized controlled trials, the Cochrane risk of bias in non-randomized studies, also called the Robbins-1 tool, and then the Newcastle-Ottawa scales for things like prospective cohorts. So again, it'll allow for better assessment of bias, not only in randomized trials, but in other documents, observational studies as well. There will also be an algorithm for study inclusion. And this is really important because it'll avoid data conflation. And so what do we mean by that? So here's the algorithm. And again, the rationale to restrict the guidelines to using just randomized controlled trials is that when observational studies are used, they're often below the level of randomized trials. They're highly biased, and they're fraught, again, with confounders, and unmanaging confounders can invalidate the statistical estimates, which can then conflate the data in a forest plot summary statistic. And what that does is that it can provide a false impression that proper evidence exists to answer our questions, which can impact things like grant funding and reducing the likelihood of future randomized controlled trials. So parenthetically, I'd like to share with you just an anecdote from a grantsmanship standpoint. So, I recently had a grant reviewed, and multiple reviewers said, the guidelines say do this, But if you actually go back at the guideline on what they were commenting on expert opinions. For guidelines to include mostly expert opinions, one of my worries as a clinical researcher is grant reviewers will go back to that and think that equipoise does not exist in that particular question, and then randomized controlled trials can't be or shouldn't be because of perceived ethical reasons. And so this is why, from my standpoint, it's important that we think about what type of evidence and what type of language we put into the guideline process, because it really does have a ripple effect. So when we go back to other components of that schema or that oversimplification of the process of how guidelines are developed, some other methodology is that Liam is going to adopt covenant software, and this software will just enhance the screening process, the data extraction process, and really bias assessment as well. And then he's going to be conducting what's called a screening calibration test, because this will allow members of the guideline panel to better agree on certain articles that were, for example, pulled. And then again, we talked about this already, but he's going to incorporate some of the latest bias tools, and that'll really enhance study quality assessment. And if we once again compare the 2016 against the 2021 guidelines, you might be saying to yourself, wow, there were 95 recommendations in the 16 and there's only 6. So what happened to the other 89 recommendations? So it turns out that many of these recommendations were expert opinion, and they were not based on high quality evidence. And recall that GRADE does not consider expert opinion a category of quality of evidence, and it represents an interpretation of evidence in the context of experts' experiences and knowledge. And in fact, experts may have opinion about evidence that may be based on studies ranging from uncontrolled case series to observations in your own clinical practice as well. But GRADE does not consider that a category of quality of evidence. So what do we do? What do we do for all those other questions? And Liam has a process built in for that as well. And so based on this algorithm, let's say no data exists, meaning there's no randomized controlled trials to answer that particular question. The next question would be, are RCTs ethically feasible? And the question there might be, no, they're not ethically feasible. And the next question might be, well, are known confounders manageable? And do we have observational data that'll tell us that? And if the answer to that question is no, if the answer is still no, well, if no quality data exists, then expert opinion via a Delphi technique that is validated by an external panel will be carried forward. And so there will be a clinical panel that will weigh the pros and cons for different recommendations, and the chair of that clinical panel will then draft recommendations, and the panel will provide an anonymous vote with commentary. And this process will continue until there's greater than or equal to 70% agreement achieved. And the chair, with the chair altering the recommendations to achieve better agreement. And then the recommendations will be sent to an external validation panel of up to 10 experts who will repeat that process until the chair of that panel achieves more than 70% agreement. So here's a summary of what we just discussed. GRADE provides a framework for specifying healthcare questions, choosing outcomes of interest and rating their importance, evaluating the available evidence, and bringing together the evidence with consideration of patients' values and preferences and the society to arrive at recommendations. Using GRADE, the 2022 Critical Care Nutrition Guideline summarized evidence within nutrition support to provide updates for several foundational questions to the provision of nutritional support where randomized controlled trials were available. And again, compared to the Aspen 16 guideline and the Aspen 18 guideline, the current 22 Aspen guideline utilized only randomized controlled trial level data. And those updates, again, in summary here, Number one suggests 12 to 25 kilocalories per kg in the first 7 to 10 days. There were no new recommendations for protein dose. So again, 1.2 to 2, but note that there are trials on the horizon or completed that should inform future protein dose recommendations. Recommend either early exclusive PN or EN. Recommend against initiating supplemental PN prior to day 7. Recommend either mixed oil or 100% soybean oil lipid emulsions, and then same, recommend either fish oil or non-fish oil lipid emulsions. And moving forward, there's multiple new methodologies that have been put into place, and some of these you'll see with the head and neck cancer guideline that will seek to enhance the transparency, the agreement, the assessment for bias, for example, and the validity of the guideline. Thank you very much for the opportunity to speak with you today. I'm happy to take any questions before we move on to the questions.
Thank you so much for this very informative talk, Dr. Patel. I do see a couple questions in the chat. So one of our questions is asking, the new guidelines have these 5 PICO questions, but don't provide comments on several other aspects of ICU nutrition. Should we see this 2021 update as an addendum to the 2016 guidelines? And there's been no literature to support changing any other recommendations from 2016. And some of the examples given are feeding on pressors, choice of prokinetic agents, post-pyloric tube placement, etc.
Yeah, that's a great question. Thank you for that question. Some of these things were considered when the guideline panel, met, and the idea was to provide updates to the 2016 guideline where randomized controlled trials were available to answer some key questions that individuals need for day-to-day practice. So, for example, related to feeding in, shock, randomized controlled trials comparing different enteral feeding strategies just weren't, necessarily available. And so there is going to be a guidance document of generated through this Delphi process that I discussed in the last few slides of this talk. I don't know when that, document is going to be, delivered, but I do know that the process is underway.
Thank you for that. For our audience, if y'all have any questions, you may drop them in the question box, and we'll definitely take them. And as we're waiting on more questions, I do have a question for you regarding the exclusive PN versus EN recommendation. Did these studies also look at some of the what we sometimes consider like adverse effects of not feeding enterally? So gut atrophy, ileuses, etc. Like, was that taken into consideration, and is it still rule of thumb to try to feed enterally unless you absolutely have to feed parenterally?
Yeah, let me try it. Thank you for that question. Let me try answering that in reverse order. The short answer is, in my practice, I still feed enterally, and I feed enterally based on the notion that a little bit of nutrition, so trophic rate EN, so 10 to 30 cc's is enough to lubricate the gut and to provide trophic functions, so to maintain gut epithelial, barrier functions. And so as long as we maintain gut epithelial barrier functions, then the idea is that we may not have any downstream, consequences of the gut motor being turned on, as a result of impaired barrier function and defenses. With regard to the first part of that question, the calories trial did not look at gut histology or biomarkers of gut epithelial barrier function or quantity of epithelial function, for example. However, the Nutrivia 2 trial did look at that. They published this data in a secondary analysis. And so they looked at, for example, the plasma citrulline levels. And the plasma citrulline is supposed to be a biomarker surrogate of gut epithelial barrier mass and function. And what they found was that those who received enteral nutrition as compared to parenteral nutrition had a higher plasma citrulline level, which is indicative of a higher enterocyte mass and better enterocyte function, I suppose, than those compared to those who received parenteral nutrition. Now, what's not known is the meaningful clinically important difference. And so I think many of us would agree that a citrulline level of more than 20, is considered, to have, good epithelial barrier function and mass. But we don't know what the difference is between groups that is considered clinically, relevant as well. And so the Nutria 2, in summary, was the trial that did secondary analyses where they had some biomarkers of epithelial barrier function.
Thank you so much for that. And thank you for also giving us practical tips regarding your practice. We have a few more questions. So the next question is asking, do you think the 12 to 25 kcal per kilo is truly representative of REE? This was determined based on kcal intake data versus delivery data. If we aim to deliver calories based on intake data, I'm afraid we'd be truly underfeeding. What's your take on this?
Yeah, that's a good question. Maybe I can parse that out a little bit and say that the 12 to 25 is based on sort of the range of calories that were prescribed in the trials that informed, the recommendation. Okay, but I agree that there's a difference between delivery and how much we're actually, going to get into our patients. I do think that the pendulum is swinging towards a less is more strategy. I mean, perhaps you heard some of that in my bias, when I presented in the less is more, slide. But the ESPEN guidelines would support this as well. And what I mean by that is, I think during the early acute phase of critical illness, the goal is not to bulk up your patients. In fact, they might be so catabolic that you're not going to be able to keep up with, what they're losing. The goal in that early acute phase is simply to prevent the bad things that could happen as a result of impaired gut barrier defenses and function. And so I agree that we may end up underfeeding our patients, but in my practice, I've sort of changed my strategy to, get to goal as soon as you can, to just provide a little bit just to nourish the gut. And then once we get out of that early acute phase, and some markers that I use to tell me that is, have they defervesced? Are there, if they're intubated and mechanically ventilated, for example, are they FiO2 requirements, action requirements coming down? If they're on a vasopressor, is that coming down? And when I start to see, some of these, then I start ramping up, my nutrition, because I think that they may be coming out of that early acute phase of critical illness. But if they're still in that early acute phase, because your oxygen requirements are still high, your vasopressor requirements are high or going up, for that matter, they're persistently febrile. Well, I think ramping up nutrition in that population, you may run the risk of, feeding intolerance, and you're going to do it despite not being able to keep up with what they're actually losing because they're so inflamed, if that makes sense.
Thank you. Our next question is saying, can you comment on the thought process around excluding benefits to the microbiome and tolerance in the selected studies?
I'm not sure if any of the studies that were presented or utilized in the guidelines specifically addressed the gut microbiota as an endpoint. What I will say is it's difficult to tease out whether giving enteral nutrition is going to have an impact where the concentration of the microbiota is the greatest, and that's in the cecum. And so I say that because when you deliver an enteral formula, most of it is going to get absorbed before you get to the cecum. And there may be blenderized formulas that can make their way down a little bit to the large bowel. However, I don't think that I've seen that data yet, and in terms of preserving gut microbiota. The other piece is that there's too many confounders when we think about gut microbiota, specifically related to nutrition. The biggest one is antibiotics, and so even if I did see a study that showed, enteral nutrition preserves the gut microbiota at the level of the cecum, I'm not sure how to interpret that, knowing all the confounders that could do that as well, or not do that for that matter.
Thank you. Our next question is asking about supplemental data that summarize which trials were excluded and why. Interested in how question 5B has only 10 trials when recent meta-analyses with more exclusion criteria included more than 20 studies.
Yeah, that's a great question. It's really important that well, number one, what I would encourage you to do is look at the recent rebuttal from, or responses really, from letters to the editors that were sent regarding the guideline. And there is a rationale for excluding some studies for the lipid emulsion questions. The strongest rationale are that, number one, they were outside of the scope of our inclusion criteria. Some of the data were only presented, for example, in an abstract form. There was one study that was excluded because a peer review manuscript was unavailable. There were 4 studies that were excluded because they were unavailable in English. And so these were 4 trials out of China. There were 4 papers that were excluded because, again, they examined fish oil as an independent drug. There were 3 studies that were excluded because they were inconsistent with the research question that was actually being asked as well. And so I think it's really important that whatever studies we include, we at least should have enough information in them that we can vet those studies to say if they're high or low quality data. Because otherwise, if we include all of the studies, then we run the risk of falsely conflating the effect estimate. And the guideline is a scientific document, and so we don't want to make any assumptions that these are high quality trials until we've actually seen and can vet and extract that information.
Thank you. Our next question is asking, what clinical outcomes do you think would be most beneficial for future guidelines to look at? For protein provision, do you think mortality or change in muscle quality would be more important to study?
Yeah, that's a very good question. It's hard pressed at this point for me to think that protein provision is going to have an impact on mortality. One of the reasons for that is because, well, a few reasons actually, but one reason is that critically ill patients are just surviving more compared to when they were like 20 years ago. So critical care survivorship has increased. Because critical care survivorship has increased, it makes it that much more difficult to design a trial. Because, so for example, if the mortality rate today is say 30%, is it realistic to think that protein is going to reduce the mortality by 10%? If the answer is yes, well, then you may not need as many patients in that trial that you're trying to design. But if the answer is no, and we think mortality is only going to change by 2, 3, maybe 4%, well, now suddenly you need many more patients to do that study. So I think that what's probably going to be more important is to look at functional outcomes, because critically ill patients are surviving more, and they're surviving and leaving the hospitals with a new baseline poor level of functioning. And so if protein is going to do anything, then maybe it's going to preserve muscle mass enough that it's going to allow for a betterment of quality of life.
Thank you. It was very enlightening, in terms of like where we are with critical care in general. I had a question for you regarding the safety of PN. Do studies, specifically as it pertains to infectious complications, do studies typically look at like access points, where it is, how long it's been in there, etc.? Or, and I'm asking this question in the context of taking care of patients with wounds or patients who may not have the cleanest central access.
That's a good question. I don't know the answer to the specific access point piece of the question, but I can tell you that the two largest trials, contemporary trials, were again the calories trial and the Nutria 2 trial. Again, thousands of patients were enrolled in each of these studies, and they both compared early EN to early PN, albeit the calories trials did it in a mostly well-nourished population, and most individuals were not on vasopressors, whereas the the Nutria 2 trial did it in a mostly circulatory shock, population, about 2/3 of them who were in, septic shock. Both of those trials, when they looked at, infections, they did look at things like bloodstream infections, and urinary tract infections, for example, but I'm not sure if they looked at the site, meaning where was the line where the infection was it next to a wound? That's something that the supplement might offer some, guidance on, but I'm not aware of that.
Thank you. I don't see any more questions from our audience.
All right, can we go to the questions? Is that okay?
Yes, absolutely.
Okay, all right. So there are 5 questions here that I've embedded into this talk, and here's question number 1. Okay, which statement best describes grade? Notice the emphasis on best. And so take a few moments and review the answer choices, and then we'll show the answer. All right, for the sake of time, let's keep going here. So the best description of grade here is choice C. It's, remember, a transparent, practical, sensible approach of rating the quality of best evidence, available evidence, and developing healthcare recommendations. This is a process, right? And so grade gives you a process, a framework, to do this. Did anybody have any questions on question number 1? All right. What is the rationale for recommending 12 to 25 kilocalories per kg per day energy? All right, let's take a look at the correct answer. The correct answer is here. It's A. The decision was based on having no evidence of benefit for and a lack of certainty regarding harms of energy provision. Again, recall that feeding people too much early, there is a rationale for not doing it, and we don't have benefit for doing it exclusively. And so this is why we have a wider range of energy recommendations. Okay, question 3. What does the new Aspen guideline recommend for protein dose in critical illness? Hopefully this was a slam dunk. All right, so here the answer is D, again, between 1.2 and 2. This was the only recommendation that did not, change compared to the 2016 guideline. But remember, there are trials underway and completed that may inform future protein dose recommendations. Question 4. what are the strongest recommendations based on highest quality of data? What are the strongest recommendations which are based on the highest quality of data? All right, let's take a look. So recall recommendations 3 and 4, supplemental PN and early EN versus PN are the two strongest recommendation in the 2022 update, and these are based on the highest quality of data, high quality of data. And question 5, which new methodology will most enhance transparency with guideline development? All right, let's take a look. Recall that Liam is going to be putting out an a priori publication of a guideline protocol. And so that protocol is for the public. They can vet it, they can make comments on it. But it also holds the guideline team, accountable for any changes in the protocol that may come after this a priori protocol is released. Thank you very much.
Thank you so much, Dr. Patel, for your expertise. We really enjoyed this talk. At this time, I think we've taken all the questions. We'd like to thank Gaspin for their wonderful partnership with the Southeast chapter. We've had some very successful meetings in the past, and this was no less. This was a great meeting. And we'd like to thank all our audience who were able to join us today. Over the next week or so, this talk will be available on the Southeast chapter YouTube channel. And we hope you enjoy your evening. Thank y'all very much.